We're really quite good at the first bit, killing cancer cells. We're not very good at stopping them from coming back.
Facing a cancer diagnosis can feel like navigating uncharted waters. You're searching for answers, for hope, for time. Welcome to the Heal Navigator podcast, where we explore integrative and alternative cancer treatments and therapies from around the world. We're here to provide you with the options, insight, and the hope you need now.
Today, I'm really excited to be talking with Ben Whately and Dr. Padman Vamadevan of Astron Health. Astron Health empowers cancer patients with personal protocols utilized in in-depth molecular analysis and bioinformatic research to pinpoint effective, repurposed drug therapies. We're going to spend some time unpacking what Astron Health is and why this personalized approach can potentially make a difference in treatment effectiveness. Hi, Ben. Hi, Padman. How are you both doing?
Doing very well. Great to meet you.
Hi, Payson. Great to meet you.
Thank you for joining me today to discuss you guys' amazing business. I believe that this will make a life-changing approach for people that are exploring repurposed medication and providing more personalized treatments for them. So let's go ahead and get right into it. Can you give me just like a quick one-liner of what Astron Health exactly is and what prompted you guys to starting it?
Shall I kick off there, Pat, with the one-liner, and then you can go into the details. So I guess the one-liner is that we're dedicated to enhancing cancer care by providing personalized treatment recommendations based on the most rigorous scientific analysis of genomic and molecular pathology data. And so what we want to do is to help clinicians and patients to access really effective evidence-based adjunctive therapies through the very strategic repurposing of existing medications. So we're sort of 9 parts of research organization, really trying to understand what are the best ways to combine these different medications. We now have incredible testing capabilities with a whole range of different genomic and transcriptomic tests. And what Astron is about is working out, given that particular mutations are present, particular metabolic pathways are overactive, what is the evidence for existing medications and existing supplements targeting those vulnerabilities in each person's cancer? So that's the research that we're doing, and really everything that we recommend grows out of that research.
Yeah,
I don't even know what to add to that.
I was just going to say, I think that's a pretty comprehensive answer, Ben. I think the only thing I would add is that we talk about precision medicine a lot, both from a kind of patient perspective and from an oncology and a public health perspective. And we've kind of tackled one part of precision medicine really well, which is the testing bit. So we have, the technology that we have even from 10 years ago is orders of magnitude more powerful. But unfortunately, the capabilities of oncologists to leverage all of that data to actually treat patients with something that precisely targets their molecular vulnerabilities isn't there yet. And that's really because there's this huge lag and delay on the conventional routes to create new drugs. They cost too much money and they take too much time for patients in the here and now. And that's the bit that we're really trying to solve. We're not trying to get in the way of new drug development. We think all of that work is incredibly valuable and is the future of cancer care. But we need to start helping patients today with existing drugs.
And there are, though, it's also worth saying there's an extent to which this very personalized treatment of specific mutations, there are 1,600 plus cancer driver mutations. The idea of waiting until we can do new drug development for every single one of those, which will take 10 plus years and $2 billion, we're simply never going to get there. And so being able to find the existing therapies that do target those mutations and are already evidence to do that is a way that we can actually get to those answers really at all. It's not just faster, it is probably the only way that we can get to those combinatorial approaches.
Thank you for sharing. And could you guys share just a little bit of personal information about each of you, just so the listeners can understand who you are and who's behind this amazing company?
Yeah, of course. So my name's Dr. Padman Vamadevan. So I am the Chief Medical Officer and one of the co-founders at Astron Health. And we're a bit of a cross-Atlantic collaboration. We've got founders from the UK and from the US as well. So my background actually is at the sort of confluence of both cancer medicine, so oncology, and also a field called clinical pharmacology, which is where we really try to understand the effects of drugs at a molecular level in patients, but also the kind of effect of patients on metabolizing drugs. And so my focus over the last 10 years has really been on translating what I know about drugs at the molecular level into treatments for cancer patients, really, by looking at the kind of basic science research and then translating that through from bench to kind of actual clinical studies. And so my career over the last 10 years has really been trying to capture data looking at patients with an established cancer diagnosis on conventional treatments and seeing whether adding, repurposed drugs, supplements, targeting metabolic and molecular pathways has improved their outcomes. And we published some really groundbreaking data on that. So that's a quick summary of what I've done. So I guess I'm a sort of precision with a background in drug design and development. Over to you, Ben.
Awesome. Yeah, I'm at the non-medical side of this. So my background is I studied neuroscience and building computer models of what would now be called AI systems. And I, from that, got into building startups and building technology startups. And I spent the last 20 years doing that. I built a language learning business to 80 million users called Memrise. And I've invested in and mentored about another 30 startups over the last few years. And the real skill of my work there is to find ways that we can leverage the power of artificial intelligence, the power of machine learning, to deliver real benefits in the real world. And I met Pad, and he was telling me about his work in precision oncology and looking at and was expressing the frustrations with this problem where we get molecular pathology tests back, and in more than half of the cases, there's no actionable therapy that the precision oncologist can give. It's this huge challenge. And the more we looked at it and discussed it together, the more this actually looked like a personalization challenge, and in fact one that is very much a machine learning challenge, where we can look at machine learning and AI. So what we have built together is, first of all, an analysis database that looks at over 100,000 published studies in order to analyze which, for these 1,600 different driver mutations, what drugs and supplements have got evidence in published papers that they can act on those. And we've actually identified more than 200,000 drug to mutation. Then from doing that, and that is possible through the use of different kinds of generative AI, then from doing that, we can analyze those further, kind of more of a machine learning problem to understand quality score against each of those, understand how strong the evidence is for each of those. And this is a process that we're building out at the moment to allow us to do a much faster route to say, if a patient has these mutations, here is all the research that the oncologist can look at. Here's how we can rank it so that they can spend their time on the most important thing. No oncologist can ever look at 100,000 papers in their entire lifetime. But what I'm bringing in from this kind of computational side is this approach of how do we analyze that material in order to make it useful to oncologists so that they can get at the right information. It's still the oncologist making the decisions, but get the right information to the oncologist so that they can make the best recommendations in a world of such incredible complexity of cancer, 1,600 driver mutations, which are combined in different arrangements within each patient. So there's huge variety in the diseases that are being treated at a molecular level. And so that's how my kind of background, moving from neuroscience and from building technology startups, I've come together with Pad to try and solve this particular problem, combining those two skill sets.
Thank you guys so much for touching on that. And since people are hearing oncologist and, assisting with their treatment plans, could you perhaps touch on how your approach may differ from conventional treatment or might work synergetically? Perhaps maybe give some examples of what someone might see on the testing, and then we can dive into the processes of getting started as well.
Yeah, of course. So I'll dive into that one. I think the main difference really is that most conventional cancer treatment historically, up until recently, really has been a relatively one-size-fits-all approach in most diseases, where large, level 1 data, as we call it, is generally based on large-scale randomized control trials. So lots of people with the same type of disease in the same situation going on a clinical trial to see whether one therapy is better than another therapy or nothing at all. And that's how data is generated in oncology. And historically, we've relied on that data to make a treatment recommendation. So you'll get patients going through with a particular diagnosis, say colorectal cancer, who will be diagnosed, they'll be staged, which basically tells us what level their disease is. Is it local? Is it locally advanced? Is it metastatic? And then they'll be put on a standardized treatment protocol, which may involve surgery to cut out the tumor lesions if that's possible. radiation, which is a kind of local treatment to kind of irradiate or burn away cancer cells, and chemotherapy, which basically is a more systemic treatment that targets rapidly dividing cells. But the thing that's consistent about all of those three main therapy types is that they are really focused on killing cancer cells. And so their success or failure is generally defined on what happens at the next set of imaging. Do things get smaller? Do they stay the same size? Do they get bigger? And that defines response, stability, or progression. It's a very short-term way of thinking, but it's how we work. Now, some of the newer therapies, immunotherapy and biologic therapies are slightly different from that. But our approach really is different because it is true precision medicine. So we are really focused on analyzing each individual's unique tumor profile at every level possible. So I know we talk about complex molecular testing, but that kind of encompasses everything from the genes, the genetic side of things. So what does the tumor DNA look like and how does it differ from the healthy DNA in your body? The transcriptome, by which I mean the sort of gene expression. So you might have a completely normal gene, but if it's being expressed at 20 times what it should be, and it's a gene that's encoding a cell division pathway or a cell signaling pathway or a pathway that enables you to create new blood vessels, that can be really helpful to cancer cells and really abnormal. So that's called the transcriptome. And actually also we look at the proteome. We look at the actual proteins that are translated out. Are there differences in protein outputs from cancer cells and healthy cells? And we also look at the metabolome. So metabolically, I know a lot of your patients probably are very focused on metabolism and the importance of the sort of different energy pathways that cancer cells use as opposed to healthy cells. And I think that the really important thing about us is that our feeling is to deliver truly precision medicine, you have to go simply beyond identifying drugs or interventions which have potential anti-cancer properties. And, you can type in pretty much, there's a lot of drugs with some anti-cancer potential, that documented from cell studies in test tubes versus, studies in mice and rats, and some small scale studies in human cancer cell types as well. You can put that into GPT or Gemini or lots of things, and you can find any drug and any disease, and you can find a rational mechanistic, explanation as to why that drug might be helpful. That isn't really precision medicine. In fact, isn't at all. What we're doing is you really need the data from the individual patient. So we are measuring that data, all of those levels that I've defined, genetic, transcriptome, proteome, metabolome. And then we are trying to use all of the pathways and the analysis that Ben was talking about earlier to match treatments that are available today, whether they be actual oncology drugs or repositioned or repurposed drugs, or even sometimes supplements, matching those to the unique biology of that patient's tumor. And so I think, we are very much positioning ourselves as an adjunct to everything the oncologist is doing. So very quickly, if I can, the metaphor I always make is that in cardiovascular medicine, if someone has a heart attack, the first thing you need to do is to restore the blood flow to the heart muscle. And, that comes with putting in a bypass graft or a stent, and that's very quick and it's very well established. But before you go home the next day, after having been cured, the cardiologist will put you on multiple drugs to aggressively optimize all those risk factors that might lead to another heart attack, whether it's high blood pressure, whether it's how thick your blood is, whether it's your cholesterol levels. They will address stop smoking and getting you more fit and losing weight and all of that kind of stuff. And that's called secondary prevention. And the research dollars that have been, spent on secondary prevention in heart attacks dwarfs the money that have been spent in actually stent design, for example. That's the bit that we miss in cancer biology. We're really quite good at the first bit, killing cancer cells. We're not very good at stopping them from coming back. And that's where our approach is. It's not just different, it's complementary to the approaches of the conventional treatment.
Thank you for touching that. And you did mention that stuck out to me about different, repurposed medications, whether, it's commonly used or more so now coming out. And so a lot of people have been asking us lately about febendazole and ivermectin specifically. There's a lot of hot language around this. Is this considered also in your testing?
Yeah, I think every single drug is considered. So it's not, the testing part of it actually is conducted by other companies. So most patients out there, specifically from North America, actually it's slightly different to where we are in the UK, in that most patients, when they're diagnosed with cancer for the first time in North America, will have some element of genomic testing carried out, and that's often covered by insurance. Many patients, it's interesting, many patients that I see don't even know that they've had it because their oncologist doesn't tell them about it because there's nothing they can do with the result 9 times out of 10. So we get that report at that point, and then we interrogate those molecular vulnerabilities, which can't be addressed by the oncologist at this moment. We interrogate that to see whether there are drugs from the existing pharmacopoeia, which is over 2,500 FDA approved drugs. Okay. And that includes the ones that you mentioned, but it also includes things like aspirin and metformin. It includes other oncology drugs that might be licensed in different cancer types. And what we look at is the strength of the data that suggests that those drugs might be effective for the patient that's sitting in front of us, essentially. So we do look at that. But I think where we try not to get caught up is by thinking that there is a combination of drugs, off-label drugs, that is going to be suitable and effective for every single patient. Actually, one of my previous roles was working at a center where we used the same combination of repurposed drugs in every patient. And when we actually audited the data, it was really clear that that combination was extremely safe, extremely well tolerated, and there were a significant proportion of patients that were really benefiting from that. But there was equally a high percentage of patients that weren't. So we were kind of getting this split response of responders that were doing incredibly well over a long period of time, and people that really weren't responding at all and were doing just as well as every other patient.
I remember being struck, coming from a non-medical background and sort of getting up to speed on how all of this works. I remember being struck, Pat, and you can fill in the details on this one, by looking at a redacted report for a patient who, I think there were like 16% of their cancer cells showed a particular mutation, and there was a treatment. I think in this case, it was curcumin that could act directly on that pathway for that patient. But this is of patients with the same kind of cancer. I think that was colorectal cancer. Maybe there'll be 10% of patients would have that, and then she only had it in 16% of the cells. So that's not going to be picked up in a randomized control trial. It's not going to be picked up across population level data. But for that individual person, that can be one of several treatments that in combination can address a lot of the issues a lot of the vulnerabilities that are present in their tumor cells. And I think that example just really helped me to understand why this is a problem of personalization. And it's almost the structure we have of using randomized control trials as the one way, the one gold standard of identifying if something is successful, means that we can't find things that are individually personalized, and it's the wrong tool for discovering those. And I think that's where we're looking to shift the conversation away from, is this drug good for cancer, to what are the combinations of drugs that we can use in order to address the vulnerabilities in each specific person's cancer. And so it's a much more complex problem, and it is one that AI and machine learning is kind of essential to deal with this number of combinations and this amount of data. It hasn't been possible previously, but now we have the computational power to really address this. And that is why it's such an exciting, new and complementary approach.
Yes, and this is what I love about you guys the most, is because I do calls, discussing mebendazole and ivermectin and mebendazole and, these more common names, safe freeze approaches, Jane's approaches, nauseous approaches, people hear from these people specifically. And I do like the fact that you guys do individualize per person, per their cancer type, per their mutations. This is very important because most people, I saw this person on social media, they had the same cancer type as me, so I'm going to do the same protocol. Well, I didn't get the response that they got. Why is that the case? From a scientific level, we understand why. But for people that might not be scientific minded, it doesn't make sense to them. So that's where these types of analysis of their genomic testing definitely comes into play, because as you guys have touched on, it does individualize for them specifically. It gives them that blueprint of what to follow.
Pat, could you give any more kind of examples of that?
I think I'm super fortunate, to have incredibly educated patients that educate me every day, but also to see lots of reports. I've seen hundreds, if not thousands now, of molecular reports from patients, often with very similar looking cancers on paper. Similar ages, similar genders, similar time of life, same tissue type. And we put people into boxes generally based on what type of cancer they have, as you mentioned just now, Padman. And when we look under the hood, the molecular drivers of their cancer, so two people with colorectal cancer, can be completely different. completely different. And that explains a lot of the differences in outcomes, not just from repurposed drugs or supplements or whatever it might be, but from conventional chemotherapy. So I think the example you mentioned earlier, Ben, was a particularly good one, actually, in colorectal cancer. So when we deliver precision medicine, the patient I think you were talking about actually had gone through 2 types of chemotherapy and had responded really well both times, but had a very quick recurrence thereafter. And chemotherapy had been really tough. I'm changing some details for anonymization here, of course. But what had happened soon after each chemo round was that there had been a disease progression, and the oncologist wanted her to go on to the 3rd set of chemotherapy. And she thought, well, this is not really extending my quality of life. I'm having to take, 6 months of chemo for 2 or 3 months of, non-recurrent timeline. So we did molecular analysis, and what it found was there was a couple of genomic alterations, number one. There was lots of changes in the gene expression pathways that we could action as well. But out of these 2 genomic alterations, one was actionable from the oncologist. So they could actually give a drug that was licensed in that type of cancer that targeted that mutation. But that mutation was only present in 16% or 15% of the cancer cells. So using precision oncology, the conventional oncologists were super excited about this. But we looked at it and said, well, it's going to hit those 15% of cancer cells. But if that 15% is the definitive subclone that is going to revolutionize our outcome here, great. But what are we going to do if it's the 85% that aren't targeted? Do something. So we actually then looked at another gene that was mutated, and there is no drug that targets that mutation in colorectal cancer. There is a drug that targets that mutation in breast cancer, but not colorectal. So we used our approach to go through all the bioinformatics pathways, and we kind of established that there were a couple of repurposed drugs. In this case, statin actually was particularly good, that targeted that pathway. And that mutation actually was hitting about 35% of the cancer cells. And then we did sort of a further adoption of our approach, looking at the gene expression pathways, and we found another 4 or 5 drugs that were incredibly useful. And you were talking earlier about different people's approaches, whether it's Tom Seyfried, Jane, there's lots of people, Naisha Winters, they all have incredibly intelligent approaches to all of this. But there are just quite a lot of assumptions because they're trying to give advice across huge numbers of patients. And we know that without having that individualized report telling you what the specifics of each patient are, you can't truly give the best advice. There is no one size fits all criteria here. And I think this is really what we're trying to do. And actually, by being able to leverage existing data that patients have, because it's not cheap getting this genomic stuff. And that's why North America is so exciting for us, because patients don't have to pay a huge amount of money to get that done, that retesting done. We can look at existing reports that are there sitting in a folder somewhere that have never been, used really for the patient's benefit. And we can sort of analyze them, audit them. And then as time goes on, if things change and we get a really good response, but something then changed, we can then reanalyze. We can see, is there a new mutation? Are there new metabolic changes? Are there gene expression changes? And we can tweak our protocol. And this is really important because I see a lot of patients that try and do everything. They try and cover every single pathway. They end up going on huge numbers of drugs and supplements, and notwithstanding the cost of that, often to just be able to tolerate those drugs, they end up taking most of them at really, really almost homeopathic doses, and what we really want to understand is what dose of each drug you need to take to get the molecular effects that you actually need to work and to, elongate. So you can't do that when you're taking 30 different drugs. You might be able to do it when you're taking 4 or 5. And that's part of what we're analyzing.
Thank you. And can we kind of touch base also on the genomic testing? Can you perhaps name common companies that people can get these testing done here in North America, and perhaps mention to their oncologist if they haven't had it done? Because there are some people they have talked to that I've mentioned about getting genomic testing done that they haven't. And it's a very common case. Usually what I see is genomic testings being ran if people aren't responding to treatment, then they start to dig a little deeper. Or if they're later stage 3, stage 4, or ones that might be more common to have these types of markers or mutations within their cancer, like colorectal, breast, things like that.
Yeah, absolutely. I think the first thing to say is that genomic reports are very different from kind of standard tissue pathology reports. So when someone is first diagnosed with cancer, often there's a tissue diagnosis where, if you have breast cancer, you'll have a tissue sample taken, or colorectal or prostate or whatever it might be. And we look under the microscope at that tissue. The pathologists look at it under the microscope and do certain specific stains to make a diagnosis, essentially. Whereas a genomic report is slightly different to that. It can be done on tissue, in which case, it goes to a high processing lab and tissue is fixed. It's something called FFPE, formalin fixed, paraffin embedded tissue. And they basically are looking at all of the genetic alterations in the cancer cells as compared to the healthy cells next to them. And it can also be done on blood. So say if you've had a genomic test done and then you've had treatment and everything's fine, and then a few years later there's a change in the cancer status and there's progression, you don't have to always go and have more tissue taken. And I know people worry about having biopsies, they're not nice, but now there is liquid biopsy or blood-based testing where a simple blood draw can actually detect circulating tumor cells or circulating tumor DNA, and that can actually be amplified, and we can do the testing on that. And often that's really interesting data, because if you think about what happens from a tissue-based test, that captures the genetic alterations or structural alterations from one particular lesion. And if you've got tumors in different sites of the bodies, one lesion here might be different from a lesion elsewhere. And the really exciting bit about blood-based genomic testing is that it captures all the different types of tumor cells, the heterogeneity of all of those tumor types, and we get to see a kind of real breadth of data there. So there are a lot of companies that do this testing. Again, our aim is not to try and compete with or replace them. That's exactly not what we're doing. These companies have been around for a long time. They do amazing work, and we are completely agnostic. Most of them use a very similar platform. Some of the common ones, and these are generally global companies, they're a fantastic company. They have a platform called the XT platform, which is really, really comprehensive and looks at over 600 genes. Guardant 360, another amazing platform. Foundation Medicine, Harris Life Sciences, Personalize, Natera, Atar Cancer Genetics. There are lots and lots and lots of them. Most oncologists will be very happy to look at any of these tests because they all use a very similar type of technology. So, your particular hospital may have a particular deal or pathway to use a particular type of test. We're obviously really happy at Astron. If anyone wants to have a discussion with us or ping us an email to advise on specific benefits of specific tests. But in general, they are all very, very good. And I have used them all really effectively to develop personalized treatment strategies for our patients.
Thank you. And can we kind of walk it by like a step-by-step process of once one does have genomic testing and wants to be involved in the analysis done through Astron Health, what is this process?
Yeah, so I think at a practical level, we have a portal that patients essentially log into, and they can essentially sign some consents, upload their clinical data. So we need a proof of diagnosis, their initial pathology report. We need their molecular report as well to sort of be able to do the analysis. And then that will kind of flag to our scientific team, and we will then review that the patient is eligible to go through our process, essentially. After doing that, we identify the molecular vulnerabilities, and that can be at multiple different levels. It can be genomic, it can be metabolic, as I mentioned, it can be at the gene expression level. And that enables us to identify what alterations are driving their particular cancer at that moment in time, or at the time when the testing was done. And then what we try and do is we use our bioinformatic platform initially to identify those weak points and look where there are particular targets that drugs that we have already can selectively block certain pathways or hit certain gene targets or even kill cancer cells. Okay. Now, after we've done that, that's the first bit of the process, the easy bit, you might say. And that gives us a kind of long list of quite a lot of drugs and supplements. What we then do is we have to then cross-reference all of that information with all the peer-reviewed literature. So we are then looking for validation studies to make sure that the kind of binding effects of that drug on that genetic target are validated by actual papers. We then construct, once we're satisfied, we kind of rank all of those relationships and we create a report for the patient which really walks the patient and the oncologist through the rationale for each drug or supplement selection. So it's not just the sort of, you have this mutation, take this drug. It is a kind of step-by-step guide to what having that mutation means, what pathways it activates, and how we're going to go about tackling that in the most proportionate and tolerable and safe way, with visualizations as well. And the aim is therefore that we then send that report to the patient's oncologist in good time, so they have time to review it, look at the targets, understand the science in a way that they can then explain it to the patient, because this is complicated stuff. And some of the approaches that we are taking, we're looking at kind of drugs that directly inhibit certain genes and gene targets. Sometimes we're also looking at something called synthetic lethality, which is a relatively novel concept that hasn't been fully leveraged, where we sometimes find gene mutations, but there isn't a drug target for that gene. So what we then have to do is we have to identify almost complementary genes that are more important as a result of the first gene not working properly. And so rather than targeting the first gene that we see on the report, we're targeting this complementary or parallel gene pair. And often we can find a drug that does do that. So when you knock out both of those genes, the cancer cell dies. That's something called synthetic.
I like the chair analogy for that one, where there are many cell processes that are held up by multiple legs. And if each leg is a gene, and if one gene's not working, the chair can still hold up. But if we can find treatments that knock out the other leg or two other legs, then the cell collapses just like the chair. And it's actually a way of targeting just the cancer cells, because all the other cells in your body that don't have that mutation won't be affected by those treatments. It's only the ones that have already got one leg of the chair is wobbly that will be affected by those treatments.
Thank you. And could you just kind of touch again on like what the typical wait time is for results for the personalized protocol? Are we talking weeks, few days?
No, we try and deliver them as quickly as possible. And obviously every single report this is not just put through a computer program. This is, a lot of it has to be done manually at the moment to make sure that every single recommendation has been kind of audited and validated by an expert in the field, one of our team. And so, it takes pretty much around 20 hours of research time per report, depending on the range of vulnerabilities. But we try to get each report back within 7 to 10 days and sooner if we can. So if there's
assuming that's once the genomic pathology report has been done.
Exactly.
So assuming that the patient already has that.
Right. This is for the analysis portion of it. Is there any way, like if someone wasn't able to obtain like a genomic testing through their oncologist for whatever reason, could you walk them through the process of maybe how to pay out of pocket and get some similar like testing done to where they can still get the analysis through Astron?
Yeah, absolutely. So I think coverage for testing kind of varies by country and provider, of course. In some cases, even if a primary oncologist isn't willing to authorize the testing because they don't feel that they have anything in their toolkit to, be able to deliver an actionable solution, we can still sort of help to get it authorized through another source. So absolutely, we can walk any patient through that process. And I think the important thing to say is that we have a lot of clinicians, again, that we work with globally who are able to then action our reports. What's really important is that we don't just send a report to a patient and it's a really nice to have, but then they can't do anything with it. So what is really, really important for us is that actually we have a partner oncologist that we can work with local to the patient, and we'll kind of confirm that before moving forward, that we can send that report with, and we know that that doctor has the requisite understanding of what our report is going to look like to be able to action it. Often those are the same doctors that we can work with to get the testing ordered in the first place. And we also have a partner that we're working with at the moment who has sort of preferential pricing across a whole range of diagnostic and genomic testing across North America as well.
Yeah, so thank you, because my next question was going to ask how, like, if their doctor wouldn't be willing to implement, say, different repurposed medications that might be necessary, do you have like a directory of practitioners, maybe not globally, but at least like in the common North America area, that might be able to assist with prescribing certain medications and helping patients obtain them?
Yeah, we do. And as you say, we can't claim to cover every single area of every single country. But what is also really interesting to say is that I think when we've sent these reports to oncologists, very conventional oncologists who have never looked at a repurposed drug or a supplement in their life, and we've sent these reports through to them and they've looked at the scientific data, and it's not just a kind of, oh, look, this is a GPT transcription of every single target that metformin might be able to hit. This is a relatively scientifically robust, peer-reviewed data trawl of real-life studies in this particular patient's type of disease. And here's actually then the binding data. So it's a kind of data triangulation process. And I think when oncologists see that, and they actually see the safety of the drugs that we're using as well, because the starting point for every single drug or supplement we recommend is a huge kind of safety trawl and a kind of established data set in an anti-cancer setting, right? And I think when doctors then see, okay, we've got a safe drug with some data in cancer, I've heard of it in cancer, but actually they've got this specific data in this specific patient with this specific genetic alteration or gene expression pattern, and the fact that this drug can hit that target, actually we've had a lot of conventional oncologists be, really on board with that, quite honestly.
And that's why, for example, we've got this partnership with the University of Birmingham in the UK, where we're doing a research project looking at minimal residual disease, but they are in pancreatic cancer. And those kinds of partnerships come from the fact that, as Pat says, the mainstream oncologists are very much on side and excited by the research that we're doing. And it totally is complementary. It's not antagonistic in any way to what they're doing. So that also helps hugely with the uptake and making it easy to work with the existing medical systems.
And just slightly building on that as well, Ben, I just wanted to very quickly say that I think a lot of people historically have come to me as a doctor, and lots of my colleagues as well, when something has changed for the worse in their disease. There's been a progression or a recurrence, or when they, and actually what I want to say is that there is a real clear rationale for being able to use this type of analysis almost across the board, really. So I'm seeing more and more patients come to us now wanting to use these tools as a kind of maintenance therapy, really. They're well people who've had a curative process, but we know, high-risk cancers like pancreatic or colorectal, for example, a lot of people recur quite quickly. Some don't, but a lot do. And so people come to us having had their surgery and their adjuvant chemotherapy, having had a clear scan, and they know the statistics. They've been told the kind of grim news that a lot of them will still recur within 6 months or whatever it might be. And they want to do something proactive, but they don't want to just take drugs all day, every day. They don't want to be on, really restrictive, interventions at a lifestyle level, but they do want to take 5 or 6 things, or maybe even fewer, that target the specific vulnerabilities in their cancer cells and may act as a maintenance therapy. And so I just want to emphasize that this is not just a reactive tool. A lot of people are using it as a proactive tool. And certainly the work that we're doing, looking at molecular residual disease, these are people who had curative treatment but might still have molecular remnants of the cancer there. At present, there's no treatment for that. Unless you can see something on a scan, we can't treat you. So we're looking at that group to see whether actually this therapy, this combination of repurposed drugs and supplements in a really precise manner, could really fit that niche in a way that nothing else can at the moment.
Thank you. As we're getting ready to wrap up our podcast, could you maybe explain how our listeners can learn more about Astron Health and your services that you offer?
Sure. So I guess the first way is you can visit astron.health, where our website, and there's a lot of information on there. There's also, if you want to find out more from there, you can book a call with one of the team, with Pad or one of the others, in order to find out more and just see whether it would be a fit for your particular case. So that's probably the best.
And what is one thing you would like listeners to take away from this conversation that we held today?
I think for me, just knowing that every single interaction that you can have with us or your oncologist or your nursing team at Hill Navigator or any of the other advocates can actually truly be personalized and precise today, not in the future, not 10 years. This is not, the promise of new genes or vaccines or immunotherapies or AI in 20 years' time. This is stuff that we can do now, and we can do it better now. It might not be absolutely perfect straight off the bat, but that's exactly why building the data and auditing the outcomes is so important for us, but those are conversations that you can start having today, and we hope will lead to better outcomes straight away.
Thank you, Ben and Dr. Padman, for your valuable insights. It's been such a pleasure and always a great conversation to have with you both. For those that have tuned in, as they mentioned, if you're eager to learn more about Astron Health, just head over to the website, astron.health. And remember, knowledge is power. The more you know about your treatment options, the better equipped you are to make informed decisions about your health specifically. And thank you to our listeners for tuning in.
Thanks for joining another episode of the Heal Navigator podcast. Remember, you're not alone. At Heal Navigator, we're dedicated to empowering you with the knowledge and resources to navigate cancer care. If you'd like to learn more about integrative cancer clinics, explore the alternative treatments we offer, or speak with one of our experienced patient care advocates, please visit our website. We'll drop the links in the show notes below. Until next time, take care and keep exploring your options.